My name is Adam Brufsky. I am a professor of medicine at the University of Pittsburgh, and I am co-director of the Comprehensive Breast Cancer Center there. The priorities and goals for me as a practicing breast medical oncologist in treating early-stage breast cancer, the biggest priority is obviously to cure the patient, but to do it in as least toxic way as possible. And what I'm trying to do is really, with the patient, decide together what the best course of therapy is. The nice thing in 2019 and beyond is that the vast majority of people who have breast cancer will be cured of their disease. It's great. Especially women with estrogen receptor positive early stage breast cancer, probably about 85 to 90% of people will not have a relapse. And the only thing that really we have to deal with, and what I tell patients, is how we get there. Everybody with estrogen receptor positive early stage breast cancer will need endocrine therapy. The real question is whether they need chemo. That's really the issue. So over the last probably 15 years, we've developed a whole series of these molecular tests. And EndoPredict, to me, is the one that offers the most information to the patient. So the two things it really offers are, it can give you actually not only whether you're high risk of recurrence and need chemotherapy or low risk and you don't, it can also tell you with an exact number what your benefit of chemotherapy is. And that's extraordinarily valuable to the patient when they're in front of you. The patient's reactions to the fact that they don't need chemo are great. I mean, I had 3 people a few weeks ago who basically were crying in my office that they didn't have to have chemotherapy, and I think it's great. It's great for me, it's great for them. I think one of the biggest things that EndoPredict does is it allows me to individualize therapy to a patient. That not only can I tell someone they have a high risk or low risk of recurrence, I can really integrate the size of their cancer, the number of lymph nodes, into the actual number, the recurrence risk I give them. I think it's very, very useful. And it really has changed the way we practice medicine. I think that this is something where you really have a test that now goes to not only the biology of the tumor, but its anatomy, and does a really good job between years 5 and 15. There still is a small but significant risk of recurrence after years 5 and beyond. And so for that reason, we really like assays that go out further in their data to help us out. And also gives you what seems to be a fairly easy to understand and easy to relate to the patient chemotherapy benefit. And I think that those are two things that oncologists who are using all the other tests really should look at and give it a try.